So thank you for having me come and share a bit more about our Connecting Care to Home strategy. And I'll go through some of these slides very quickly because Patrick did share some of this information with you in his presentation this morning. So just an overview of the presentation. Emma, if you I'm going to talk just very briefly a bit about the Southwest LHIN, which is the catchment area that we would be providing care for, and then a bit more about the Southwest LHIN Home and Community Care Team, then a bit more on our project Connecting Care to Home, and then what are our patients and providers saying about this system approach to care, and then perhaps we can have some time for questions. So the Southwest LHIN catchment area is about 1 million people. We have this large urban population again, which is around 400,000 people. And then we stretch to the northern part of our LHIN area where we have communities of less than 1,000 patients. So as we try and provide equitable access to care, both to primary, acute, and secondary care, it's very challenging to be able to do that in our small rural communities. You might be interested to learn that in the Southwest LHIN area, we do provide home and community care to about 60,000 people annually. So that is 1 in every 17 people that we have penetration for home and community care. We provide about 2.8 million in-home visits annually. So we work with 3,200 patients to get them from home and transition them out into the community. Again, we help access beds for patients for long-term care homes, and we do that for about 280 folks a month. Again, we have a school program and an in-home program for complex children, which supports about 2,000 children. And again, on any given month, we would have about 25,000 patients on our roster. Again, just building on what Kathy and I talked about this morning, accessing home and community care, this is not a medical referral model. Anyone can access services in the community. It can be a patient themselves, it can be a family member as long as they have the consent of the patient, it can be a family doctor, it can be public health members, it can be a variety of referral sources. And what we do find is we can go and do an assessment. We can see a patient in the home. We can see a patient in a hospital environment, a retirement home, or in the school setting. So we do multiple assessments in multiple locations. And as we talked about, and I think Debbie talked about this morning, is what we see as a true value add in the care coordination system in Ontario is the role of care coordination. So that is somebody that is accountable to look at wrapping care around the patient. So it's a single point of access for how patients can navigate through the system. Health systems are a challenge no matter where you live, what country you're in, and we find often that patients or family will call us just wanting to know how to access services. Sometimes they need our home and community care services, but other times it's just accessing other services such as meals, retirement homes. How might I access that? So I think it is a support that we have in Ontario that is not to be underestimated, and the value add of care coordination we continue to support. So next is our CC2H model, and really it is looking at integrated care that is supported by an enabling technology. And I think the success that we've had demonstrated in Ontario and certainly in the Southwest area is we always talk about these programs as a clinical care delivery model that is enabled by technology. And I think when you talk about it in that way, it actually helps us get the buy-in and the support from our clinicians. Instead of coming at it as a technology first, it has to be about the right care delivery model. So, you know, I was thinking about what has made this difference. Over the years, we have talked about the high users of the healthcare system. And one of the high users of the healthcare system in our area was that COPD population. So we sat back, we thought, how do we look at them different? We kept talking about they are high users, they use the emergency department, they're admitted frequently to hospital. And often those visits are avoidable. So how do we do it differently? So it is every once in a while a new technology and an old problem and a big idea turn into an innovation. And when I think about that, that is really what sums up what our Connecting Care to Home is about. So our current healthcare system in Ontario is a patchwork of uncoordinated services, regardless of where you are in Ontario. We're a bit fragmented between patients, families, providers, hospitals, and community services. Often we were finding that our patients, especially our COPD patients, had a number of providers in the home. They could, for their home and community supports, have 4 or 5 different agencies involved with them. There was lack of a really solid communication and transition plan between hospital and back home and into our primary care providers. Again, we had a really long length of stay and high readmission rates. And again, there were really not good standards of practice and good clinical practice in the community. And again, there was tremendous variation in our quality. Patrick talked about this morning, I think it's everywhere that there is a case for change. The demographics of our aging population and those over the age of 65 are increasing. So we have to look at how can we provide care differently with a higher quality and more efficiency. And what we do know is in the Southwest Lynn catchment area where we are, we have a higher than average burden of chronic illness than some of our colleagues across the province. And that has made us think even more about this chronic disease population. Again, the case for change. We've had lots of focus in Ontario with talking about HealthLink's approach. We're really talking about the top 5% of the population that are accessing healthcare services. The population we need to look are that rising risk of population. So what we talk about is the next 30% of the population that have those chronic diseases that we have to figure out how to intervene earlier so they don't become that top 5%. So again, when I think of connecting care to home, what we saw as the most significant change is this was collaboration between our acute care partners and the home and community care world. So what we did is we white labeled the care team. So you weren't a hospital care team member, you weren't a community care team. Your name tags all said care team. Clinical care team. That's all they said. It didn't say who you were from. And it really included our hospital team, our inpatient team, including their navigators, respirologists, RTs in the hospital, our service providers in the home, our TACs, and our clinical care coordinator. You were all one team. So it didn't matter of saying, well, they're from the community, they're from the hospital. And I think by wrapping that care around the patient was one of the most significant changes for our patients and families. So Patrick talked a little bit about this next slide this morning. It really talks about when the patients come into acute care, they're identified very early by a navigator, and we have a risk stratification tool that we use. And patients that come into the emergency department and go on to admission, they're identified very early. If they're a mild COPD, the navigator works with them to connect back out into the community for some of the more ambulatory programs. But if they are a moderate or more complex COPD patient, they're referred right away over to a clinical care coordinator. And what we have found is that clinical care coordinator role, so she sees them in the hospital, follows them through their journey there, and then she's the same person that goes out to see them within 24 to 48 hours of their discharge. So what's critical about this, they're not getting different information. The same information they got in the hospital is the same information they're getting when they're going home. They're not having duplicate or unnecessary assessments because the assessment's one single person. So that's been huge success. And then again, what's been very important for this program is once the patients are stabilized and they've gone through their journey, how do we help them with self-management? And how are they going to take on accountability to manage their disease ongoing? So it was really, it's a new system approach for us in our catchment area. We had very strong relationships with our acute care partners, but this just took it to the next level. We had shared accountability. I cannot stress enough the importance of executive leadership and support on both sides. So you had to have an executive leader that was supporting this and believed in this and believed this was the right care delivery model on our acute care side, as well in the home and community care side. We both equally had to take accountability for this, and we had to believe in this. Again, it was an integrated care team, so one single care team. And also, we developed the care pathway together. So we had the respirologists come to the table, we had primary care physicians come to the table, we had the home and community care team come together. So there was equal buy-in and equal support and equal agreement for the clinical care pathway. Again, consistent education was critical for these patients. Many of these patients have had this disease burden for many, many years, and what they would often say is, you know, this time I was in hospital, I got this little pocket of information. The next time I got this little pocket. So there was not really a consistent education practice. The other thing is when we started doing the drill down on the reason patients present in the emergency, it was often because they were in a panic at night. At 2 o'clock in the morning, they woke up, short of breath, they panicked. They forgot how to use their puffer, they forgot what to do, they forgot how to do some energy conservation. So by having a 24-hour hotline for the patient to call, that was one of the directing nurses that actually knew the patient. They could go in and look at the data that was housed within the eShift platform, and they could walk through with the patient, and often these patients were able to settle and be able to remain at home. So again, this slide, just repeat, it talks a bit more about focusing on population health rather than episodic care. Again, it's evidence-based. We have research that we'll make sure you get that research brief shared with you that validates that this is the right care model in the home. And again, the patient experience and evaluation has been critical. Again, I think these next slides on the virtual integration and the model itself and the data are self-explanatory, and I think Patrick went through many of them this morning as well, so I don't want to replicate. I think maybe if we move over to the performance outcomes, I think this is critical, and we do have a placemat that we brought with us that summarizes these slides. It goes through our objectives, it talks about our evaluation data, and it talks about some of the successes we've had. But for our hospital partners, their length of stay when they started out with this protocol on average was 8.1 days. For some of the patients, they were up around 11 or 12 days length of stay. We've dropped it down to 3.9 days length of stay, so that's significant. That's a 52% drop in their length of stay. But even for the home and community care support program, we had these patients on for 150 days. We've been able to drop down to, on average, 34 days. Again, there was a high volume of readmission rates with these patients. We knew that many of the CTAS and ones and twos were still going to be there, but the lower level emergency visits, which we would call avoidable emergency visits, we've dropped down to 0. The patients just aren't presenting there. We believe that's a combination of the whole care team, but it's had a significant, I think that's a response to the 24-hour hotline, where the patients were able to walk them through to be able to stay at home. Again, hospital, we look at total system savings, and this program, we've had a 53% reduction in system costs, both the hospital costs and our costs in the home and community care sector. So that's huge for us. We look at this, so we would say those cost savings, as well as that length of stay, being able to get patients back out in the community sooner and with a higher quality of care has been huge. Over the last few months, I've had the opportunity to go out and do home visits with a number of our patients on this program and talk to a number of our physician partners and colleagues. So I thought I'd share some of those patient quotes and some of the team supports. So I met with an LHSC, one of the residents in one of the medical programs that was supporting this patient, and he said it's great because it really gives the patient that wraparound care. These are very typically high needs patients, and CC2H helps fill the gap and makes everyone feel supported. Again, it's great being able to see the patient at home. Usually we're caught off once they're discharged, but now I can actually see that they're doing well at home. So often we would hear our primary care physicians say, gee, I don't really know what happens to them when they end up in acute care. But we were starting to hear from our acute care folks saying, well, I don't know what happens with them when they go home. So this has been that shared opportunity for both teams to actually be able to understand each other's world. And as part of this program, the most responsible physician for the first 30 days remains the hospital specialist. And that was a great security and comfort to our primary care physicians, because they would say, I'm willing to take on the care of this patient, but I need a soft, warm handoff from our specialists in the hospital. So it's created much more synergy and energy between the teams. And then this was a patient that I went out to see just a couple of weeks ago. And he said, I've had COPD for 15 years. I was always nervous coming home from hospital. And he said this time was really different for him. My wife and I feel so supported that we can relax. And he identified over the last several years, he would say on many of his admissions, he went right back into hospital, and it was all about panicking. He said, I forgot how to do this, I forgot how to do that. And he said just being able to call up and be able to get a response on the phone has been huge. Another patient we talk about is Hugh, and we do have a video that we can share at some point if you'd like, Patrick, that we can send out. And this was a patient that had been in and out of hospital many, many times annually. He'd had a long-standing history of chronic COPD. And again, he's been smoke-free since 2015. No exacerbation in his illness since October of 2015. And for the first time, he was actually able comfortably to go away and visit with his family. And that was a first for him, and that was a tremendous goal. And again, able to complete his breathing exercises on a regular basis. He knows very quickly if he needs to be reattached and come back on for supports, that can happen. But he's also been able to do some of his own self-management and take accountability for his own health care. So what are the critical success factors as we see them as part of our CC2H work? Physician participation. You need to have that continuous support between the most responsible specialist in the hospital out with your primary care colleagues. Again, what we found is we heard early on from a respirologist in hospital, it's great, I send these people home, I get 20 different service provider nurses looking after them. I don't know who they are, I don't know what their level of expertise is. So we actually had the frontline providers get to know. They needed to get to know the respirologist so they could come in, they could have a visit. It's a small team of care providers providing the care. They develop a relationship. So then they develop a comfort and they feel their patients are able to go home and be managed. Again, having the virtual rounds, being able to use the dashboard of indicators, which Patrick talked about this morning, that's critical for them to be able to see in real time what's happening out in the patient's home. Again, you're shifting from that crisis manage to a much more proactive response and being able to manage these patients' care. Again, the warm handoff to primary care. The integrated team is critical. One care team providing care. Families don't care whether you're an employee of the hospital or you're an employee of home and care. They don't care. They just want to know that there's a team of folks wrapping around them when they get home, and that those team members have shared access to the data so they don't have to keep repeating their story. Again, coordinated and a single source of education. So we're all using the same education material. We're all sharing that education material when we get the patient back home. And again, we cannot underestimate the power of the real-time access to the information that the eShift platform has been able to support, and the 24-hour live 7. So what are the next steps? So again, we continue an analysis of our integrated funding model as part of an Ontario model of care. We've been one of the most successful integrated funding models in the province of Ontario. We've enrolled, I think to date, about 184 COPD patients, and now we're into the CHF population and we're in excess of 30 patients. Again, we'll need to continually evaluate. We'll have to look at what are the successes with the congestive heart failure population. We'll have to tweak that pathway as we go along, but it's still early days. And then what's next? I would say that our acute care partners are chomping at the bit. They're starting to think about, could we apply this to the mental health population? Is there something here around the stroke population? Is there something here around the diabetic? We would work with our acute care partners saying the opportunities are endless. The populations that can be supported by the enabling technology of care delivery are endless. We're just going to have to think about which is the next most important population. And again, what is critical, and I believe it is everywhere, but it's certainly a huge focus of our patients first transition, is around the patient experience. How do we listen to our patients and understand what they're telling us is important to them? And I think this did turn the paradigm around a bit. Instead of us saying, this is what they need, it was really sitting down and listening to them each step of the way. We had patients involved early days when we were developing the clinical pathway, so having them there as an active participant has been huge. And again, then continuing to engage our physician partners every step of the way has been critical. The other thing is the CC2H program was very fortunate that in June, we were acknowledged by 3M for a National Quality Team Award, which is quite a prestigious award in Canada, and it really was about innovation and quality, and looking at that patient experience and how might we make it different. So that was a great recognition in Canada for us. So thank you.